Hi everyone, welcome back to the Dr. Sia channel. In the video here today, we're going to be talking about the last most common ISTDP practitioner mistake in this playlist, and that is not calling things out when things should be called out. Let's get started. All right, so one of the most common mistakes that I've observed myself make when I was a beginning practitioner, and that I observe my students make, and I hear sometimes my colleagues say that they make, and sometimes I catch myself making those mistakes again, and so on and so forth, is not calling things out. And what I mean by that is, ISTDP is such an extremely effective therapy because all in all, it's found a way to, together with the patient, in a mutual collaborative method, call things as they are. Call them out. Yeah? So what do I mean by calling things out? I mean, say it. Say what you see. Discuss what you see. If you see something, say to the patient, you see that thing. And this sounds so extremely simple. It sounds like, well, duh, of course I would do that, but no, it's not of course. And when I watch my students' videos and when I watch my own videos of making this mistake, there is a trepidation, there is a fear, an anxiety, if not a sense that when we go against the patient's patterns, their defenses, and we don't get sucked in by their kind of defensive pattern, it does not feel good when you start out and do therapy. All in all, it doesn't feel too good to do that because the patient's patterns are meticulously and evolutionarily and biologically, psychologically, and socially tailored to do a particular thing, which is to bond the parent to that person in the absence of more healthy ways for the parent to bond to that child. And I'll make more videos about attachment. I can see that that's probably what people are the most interested in. So I'll make more videos about that. But so that's what the defenses are built to do. And the problem with those defenses is that by and large, they are not contextual. They tend to be cross-contextual, meaning that when the person gets anxious or stressed, they do that same powerful thing that they've learned to do as a baby automatically with anyone who gets close to them. That includes you. So that means that when they see you, automatically within them, this really powerful thing comes across their side of the room to your side of the room and wants to say, for example, don't ask me any more questions. Don't ask me to talk anymore. You just tell me what's going on and allow me to sit here quietly. You tell me everything, I know nothing. Tell me whatever you want, it won't matter anyway, you're going to hurt me at the end of the day. And I'm going to do anything and everything within my power here to keep a chaotic role with you. These are the kind of things that the patient is saying as they come in. They're kind of communicating an overall holistic attachment structure, if you will, with you. And your role, your job in that moment is to call that out. And every therapist does that in different ways. Alan Abbas in his ways, John Fredrickson in his, Patricia Colvin in hers, my supervisor, Dr. Stephen Arthy in his. But what I've noticed, all in all, is you have to call it out. And as you do, you can be gentle, you can be careful, you can be collaborative, or you can be combative and nasty about it. So don't be combative and nasty about it, but call things out. Now here are several examples of calling things out. The patient sits down, they appear avoidant. Okay? through a series of defenses that are avoidant related, such as repression, such as isolation, such as detachment, such as short replies, such as intellectualization, such as rationalization, such as reaction formation, such as sublimation. You get the point. They're kind of sitting there, they're doing all those things. And look, you can very early on call it out and say, it seems like you prefer to be avoidant. It seems like here with me, I ask questions, but at each point that questions come from my side, you prefer to avoid the topic, for example. Is that right? Do you prefer to avoid this topic of you? The patient might say, yeah, I prefer to avoid it. Then you can say, do you want to avoid it right now? Is that what you want? You want to avoid yourself right now? You don't want to talk about you? No, I actually don't want to. And then you can explore that with them. So how come you came in? I don't know. I really wanted to get help, but as soon as I sat down, I felt that suddenly I don't want to talk about me. Is that common for you? Yes, it is. Does that happen in many situations for you? Yes, it does. Which situations is that? This, that, and that. So you start exploring with them the avoidance that they have. Because if you don't explore that with them, you're just going to have these piecemeal defenses that may or may not be beneficial to the patient to explore, but you still would sit there with an avoidant person who syntonically within themselves, who consciously within themselves prefers to avoid having the conversation with you. Now, most of my students will say, so how do I address that? The more important part is not how, the more important part is that you do. First you do. Then, once you start doing, then you can start focusing on, okay, well, how can I improve the method in which I do that? Now, mine is is something that I've learned from Dr. Stephen Arthy, but you could use whatever. You could say, at the end of the day, hey, it seems like you're avoidant. It seems like you don't want to talk. It seems like you prefer not to be here. Seems like you prefer not to be having any of these conversations right now. Seems like you prefer for me to ask all the questions and for you to have no questions be asked of you, or for you to so on and so forth. So the example that I gave was with avoidant. Let me give you an example with a person who's ambivalent. So you might say, for example, all right, it seems to me like whenever I ask you a question about you, you get distressed. But whenever I say something about you or interpret something about you, then you kind of calm down. Is that right? Yes, it's right. Okay, it kind of seems like you prefer to just sit here and for me to talk. Is that right? Yeah. What's that about? Let's have a look at that. That's not collaborative. That's not cooperative, right? You don't have to say that's not collaborative, that's not cooperative, but you can say, what is that about? Let's have a look at that. How can we be equals? How can we be two people sitting in a room working together, not me working on you? Because that's not going to work for me to sit here and work on you on something. We have to be able to work together on something. How can we bring you into the room? And so on and so forth. You can call things out. Let's use an example with a disorganized patient. Of course, as you know, with a disorganized patient, it's going to mostly be externalizing projection and so on and so forth. That's going to come and right into the room. And you have to look at that. Hey, it looks like you are afraid of me. It looks like there's some part of you that says that I am dangerous to you somehow. Are you worried that I'm going to criticize and judge you somehow? Sounds very similar to avoidant attachment, but again, their ideas will be much more solidified, that it's not just an idea that I have, I actually think that you're dangerous. So you need to be able to call things out. If you get that eerie sense within you when you're sitting in therapy that something's going on and you sense it, but you're afraid to say it, then you ought to say it. Say it. Because if you bring the elephant into the room, at least you can talk about it. And that patient of yours will have a better therapy session than they've had anywhere else, because at the end of the day, someone was truthful with them and someone saw past their defensive structure and actually called out the structure. So that's all you need to do to start being much more effective already today. Go in, sit in therapy. When you get a sense of something, call it out. Don't be a douche about it. You don't have to be harsh about it. You don't have to be combative about it, but you can just call it out. Give that a try. Give that a try today, and let me know in the comment section how you are going with your patients, if this technique has improved your sessions with your patients. That's the end of our top 10 list of most common, most common ISTDP practitioner mistakes. I hope you enjoyed this playlist, and I'm going to go back now to make many more attachment videos. I've had so many questions about attachment, not a lot of questions about ISTDP practitioner techniques, which I'm kind of thinking maybe that's because you all are supervised or something else, I don't know. But anyway, so a lot more on attachment. Other playlists coming up: attachment and suicide, attachment and relationships, attachment and psychopathology. Lots more on attachment this year. So I hope you enjoy it. Please subscribe. Please let your friends know. Please press the bell button so that I can pop up on your screen. And yeah, that's it. Okay. Alrighty. Thank you.